Thank you so much. I now request Dr. Neena to talk on the complicated cataract, challenging cataract cases, pediatric cataract cases. Ma'am, a humble request to please finish if possible, less than the time.
Yeah, I'm sorry I'm at this point. But anyway, thank you for this opportunity. I'll try to make it as fast as possible. Is my screen visible? So we know the challenges in pediatric cataract surgery are keeping the visual axis clear and capsular management. So I would just share a few cases which I had with me of posterior capsular challenges. So the screen is not moving. I'm sorry. Yeah, so this was a 2-year-old male child who came to us with intermittent inward squinting. And what we found that he was not cooperative with slit lamp examination. And this was his anterior segment picture on torchlight examination. You can see a central globular reflex resembling an oil droplet. So we were thinking probably it's a subluxated lens. And retinoscopy also showed an irregular reflex with a central opacity in the right eye. So we did a B scan. An ultrasound B scan showed a conical protrusion of the posterior lens capsule. So that was suggestive of something, and the rest of the pediatric and systemic examination were within normal limits. So we decided to take him up for an examination under anesthesia with a cataract surgery and IOL implantation if there is a need for that. So I'll just quickly run the video. So we can see that on the table, there was an oil droplet appearance, but as we were going, we realized actually it was a case of posterior lenticonus. And once the rhexis was done and the posterior capsule was visualized, what we could see was that there was an area of actually absent posterior capsule. Actually, that entire posterior capsule was just absent in that area, and it was filled with a bridging tissue. So you can see here, I'm actually trying to do a posterior capsular rhexis, and I'm not able to hold anything. It's just a central area of epithelial cells covering the defect. So this was actually posterior lenticonus with, just epithelial cells filling the gap. So I decided to switch on to cutter mode and remove the whole thing because I couldn't do any posterior capsular rhexis. It was already absent. And we completed it with the rhexis. And finally, 3-piece IOL was implanted with optic capture. So since we anticipated the whole thing, we used reduced parameters of irrigation aspiration. I deferred hydrodissection. The entire thing was done with bimanual IA, and care was taken to avoid AC shallowing because here hardly there is not much cataract, but if it's a larger or a total cataract, you can expect some lens matter falling into the vitreous cavity if you do a vigorous hydrodissection. So for lack of time, I would just skip the video details. So this is with the optic capture. Finally, at the end of the surgery, we got a good outcome. So just for people to update you, posterior lenticonus is a bowing of the posterior lens capsule with progressive degeneration of the lens fibers, often associated with posterior capsular defect and cataract. Because of the intralentricular pressure and zonal attraction, there is often cataract progression. And some people even think it's due to, it's related to a persistent hyaloid artery. Mostly it's unilateral, sporadic, and isolated, but bilateral cases think about systemic conditions. It's like, Lowy syndrome. So sometimes these are, some other rare signs you get, like this fishtail sign. Can you see the movement of the cortex? So there is a posterior capsular defect through which the lens matter has actually herniated into the vitreous cavity. And when you're moving the eye, you can actually see the cortex in the anterior vitreous cavity. So you have to be very careful, avoid hydrodissection in these cases. And, you have to manage without shallowing of the anterior chamber at all points. So there are a lot of other signs. You can look up the literature. So we move on to the second case. This was a 1-year-old male child with intermittent exotropia who came to us. Again, there was a central opacity on the retinoscopy. We found a near total cataract on torchlight examination. He was uncooperative for slit lamp examination.
Can you please conclude because we've ended the talk and they are pressing us to clear the session.
Yeah. Okay. So I'll just summarize. So we had this egg in the eye appearance. So this was a clue. So the egg in the appearance shows the fibrosed posterior lens capsular edges. So this is actually a case of congenital posterior capsular defect, which has progressed to a near total cataract. And you can actually, if you look carefully on the table, you can see this defect. And if you do a B scan pre-op, you can actually see this, curvature of the posterior lens capture with lens matter actually, herniating into the vitreous cavity. So I'll skip the surgical parts because we saw the posterior capsular defect on the table, and like the previous case, we managed without shallowing of the anterior chamber. We put in an IOL, we avoided hydrodissection. So again, this is a large posterior capsular defect here. You can pick it up on B scan. Child did very well. So the case 3 was again a girl who came to us with intermittent exotropia. She had a central cataract, but I could see the fundus on dilatation, and what I found that there was a stalk. I thought there was a stalk running from the disc to the lens. But when I did a B scan, I didn't find anything. So this was her appearance, a small central cataract, but the axial length was okay, comparable with both the eyes. So was it PHP? I was doubtful. But on table, I would just quickly run this video because it is interesting. After doing the capsulorhexis and the posterior capsule, I'll actually show you the steps. So we found that there was actually a stalk here. Can you see that? Can you see the stalk there? So this was a stalk. So we actually cauterized the stalk. And because we anticipated it, we were able to get an endocautery and cauterize it and put a 3-piece IOL with optic capture, because otherwise it would have bled tremendously and created problems for you. So this was a case of mild posterior PHPV which presented to us in this fashion. So what I would like to say is that pediatric cataract lens aspiration is extremely easy, but because the children are not cooperative for slit lamp examination, look at the morphology properly, do B scan properly, and anticipate problems like this. If you plan well, you can get a good results. Thank you.